morning, everyone. This is Dr. Veena, a junior resident from ESIC Medical College, Bengaluru, Karnataka, from India. I'm presenting a presentation on the significance of two-dimensional echocardiography in hypertensive disorders among pregnant women. Next. Coming to the introduction, pregnancy is associated with hemodynamic and hormonal changes which can affect the heart. From the first trimester in pregnancy, there is an increase in cardiac output, which places a volume load on the heart. This is physiological. The hormonal changes include increased circulating estrogen and relaxin, which may directly or indirectly affect the heart. Structurally, the expanding plasma volume seen during normal pregnancy is reflected by enlarging cardiac end systolic and end diastolic dimensions. However, septal thickness or the ejection fraction does not change. This is because the dimensional changes are accompanied by substantiative ventricular remodeling, which is characterized by left ventricular mass expansion to about 30 to 35% near the term pregnancy. Next. Hypertension is the most common medical disorder which is encountered during pregnancy. It complicates 5 to 10% of all pregnancies worldwide, contributes greatly to maternal and perinatal morbidity and mortality. Preeclampsia syndrome affects approximately 4 to 5% of all pregnancies. Preeclampsia is associated with significant cardiovascular morbidity during pregnancy and also later in life. Left ventricular dysfunction, both systolic and diastolic, is known to occur in hypertensive disorders. Diastolic dysfunction, it usually precedes the compromise of systolic function in hypertension, and it can lead to heart failure or pulmonary edema. If we can identify any form of cardiac dysfunction along with its severity during early pregnancy, it will help us to prevent the progression of the condition and also to prevent the complications associated and save the mother from severe morbidity of acute heart failure. Next. Hence, echocardiography, it is the use of ultrasound and Doppler to determine and examine the heart, which is safe, powerful, and non-invasive and a painless technique. The echocardiography uses the ultrasound energy of frequencies ranging from about 2 to 5 megahertz for adults. In the heart, the velocity of sound is 1,540 meters per second. The 2D echocardiography gives a snapshot in time of a cross-section of tissue. If these sections are produced in quick succession and displayed on a screen, they can show the real-time imaging of the heart chambers, the valves, and the blood vessels. Next. So in this picture, you can see on the left-hand side, the echocardiographic picture of a apical four-chamber view of an adult heart. And on the right-hand side, we can see the picture of echocardiographic imaging. Previous slide. Along the long axis where all the chambers as well as the outflow tracts are visible, and if any abnormality and the measurement can be measured in this. Next slide. These are the normal echocardiographic ranges. The left ventricular internal diameter end systole, it is normally 2 to 4 centimeters, whereas during diastole, it is 3.5 to 5.6 centimeters. The wall thickness during the diastole of the interventricular septum is 0.6 to 1.2 centimeters. Posterior wall is 0.6 to 1.2 centimeters. The thickness during systole, again, about the interventricular septum is about 0.9 to 1.8 centimeters. The posterior wall is 0.9 to 1.8 centimeters again. The fractional shortening is 30 to 45%. Ejection fraction is 50 to 85%. Left atrial diameter is 2 to 4%. The aortic root diameter is 2 to 4 centimeters. Right ventricular diameter is 0.7 to 2.3 centimeters. These are the normal echocardiographic ranges. And if any measurements changes, so we can see the abnormality and detect it earlier. Next slide. The aims and objectives of my study were to assess the maternal cardiovascular function using the echocardiography in women who have been diagnosed with hypertensive disorder of pregnancy, and also to know the maternal and perinatal outcome. Next slide. The methodology of my study, it is a prospective clinical study conducted in my department of obstetrics and gynecology at ESIC PGIMSR Hospital, Rajajinagar, Bengaluru in India. The study period was from January to June 2021. It was conducted in the Department of OBG jointly with the help of cardiologists for 2D echo assessment of the study groups. And women who all will fulfill the inclusion criteria have been enrolled. Informed and written consent was obtained, and a two-dimensional echocardiography was performed by the cardiologist in our hospital, and the maternal and perinatal outcomes were followed up. The inclusion criteria: the pregnant women of the age of between 20 to 35 years with a singleton pregnancy and who have been diagnosed with hypertensive disorders were included, excluding multiple gestation, severe anemia, pre-existing heart disease, and other associated medical illness like thyroid and epilepsy were excluded from my study because they already have a pathology in them. Next slide. Statistical analysis, a descriptive data was shown by means and standard deviation, and a two-tailed p-value was used, and if it is less than 0.05, it was thought to be significant. Next slide. The results and observation of my study was a total of 300 women were included in my study, and the majority of the women, that is 73.4% of the women, were aged between 20 to 25 years, whereas 23% between 26 to 30 years, and more than 30 years, only 3% women were included. And coming out the parity, in my study, majority of them were primigravidas, accounting for 66%, whereas multigravidas were 34%. Next slide. The gestational age, majority of them were term gestation of more than 37 weeks per period of gestation, about accounting for 65%, and only less than 13% were preterm, like less than 32 weeks. And the severity of pregnancy-induced hypertension, in my study, there were 43% who were diagnosed to have preeclampsia, 35% with gestational hypertension, 19% had superimposed preeclampsia, and 4% had chronic hypertension. And coming on to the mode of delivery, among them, about 62%, even with having this hypertensive disorder, they delivered normally. About 62% who had a normal vaginal delivery, whereas only 38% delivered by a lower segment cesarean section for indications like fetal distress and other maternal complications. We had induced a lot of patients with who had indications at term gestation, and they all delivered normally. The echocardiographic findings, about 65% of the study group had normal echocardiographic findings, whereas only 35% had abnormal findings. Next slide. So this was a distribution based on echocardiographic findings among the study groups. Among the 300 women, a total of 196 women had a normal study who didn't have any changes in the echocardiographic findings, whereas the rest 104 women had some degree of echocardiographic changes, like grade 1 diastolic dysfunction was present in 40 women, grade 2 diastolic dysfunction in 15 women, concentric left ventricular hypertrophy in 44 women, peripartum cardiography in 1 woman, and other structural and functional abnormalities in 4 women. Next slide. So this is the distribution of diastolic dysfunction among the women who had gestational hypertension. The grade 1 diastolic dysfunction was among 14 women, and grade 2 was 4 women. But among the preeclamptic women, 26 women had grade 1 diastolic dysfunction, and 11 women had grade 2 diastolic dysfunction. So hence, it's been told that preeclampsia has a higher degree of diastolic dysfunction. Next. This is the comparison of echo parameters, the significant value. As you can see among this group, the left ventricular internal diameter of the diastole and the systole, then the interventricular septal diameter, then the posterior wall diameter, then the left atrial diameter, left ventricular ejection fraction, and the E/A ratio, that is the peak velocity during the systole and the diastole among the mitral valve, have been measured and have been found significant. Next slide. And the distribution of left ventricular ejection fraction. So most of them, among 90%, had a normal ejection fraction of more than 60%, whereas 18 women had between 51 to 60%, and only 2 women had less than 40%, which was a complication. Next slide. And coming on the perinatal outcome, only 20 babies required an ICU admission because they had to be induced and they were preterm. And some form of fetal distress was also accounted, whereas 55% of the babies had a birth weight of less than 2.5 kgs. Next slide. Coming on to the discussion, echocardiography is a non-invasive and safe technique. In our study, we have studied that the significance of two-dimensional echocardiography in evaluating the maternal cardiac function in women with hypertensive disorders of pregnancy. In our study, majority of the pregnant women belong to the age group of between 20 to 25 years. The mean age was between 23.54. This was comparable with the study done by Nuzad Zaman et al., where the mean age was 27.4 years, and the mean age in the preeclamptic group was 30.5 years, whereas in the study done by Melchore. In our study, majority of the subjects were primigravida, accounting for 66%. Similarly, in the study done by Melchore and Shahul et al., 61 and 81% were primigravidae. In our study, majority of the study subjects had a gestational age of more than 37 weeks of 65%. It is also comparable with studies by Simmons and Melchore. Next slide. In our study, we had 35% of women with gestational hypertension, 43% with preeclampsia, 19% with chronic hypertension, 4% with superimposed preeclampsia. This was comparable with the study done by Parikh et al., in which study also 8% had chronic hypertension, 50% gestational hypertension, and 42% had preeclampsia. The mode of delivery in our study, about 62% delivered vaginally, whereas 37% of women required a cesarean section. Comparable, but while in contrast, the Sajid et al., the majority of the women were delivered by a lower segment cesarean section, about 81%. And echo abnormalities, in our study, the incidence of variation in structural and functional parameters was noted among 34% of women, compared with the study by Tanuja, where 20% preeclamptic women showed variations in the echo parameters. Next. Similarly, in the study done by Solanki, previous slide, the left ventricular diastolic mass, the TVR, the EV velocity, PK velocity, these are all the parameters of the echo. They were more higher in the preeclamptic group. The study by Simmons concluded that the LV hypertrophy in normotensive and preeclamptic pregnancy matches the changes in cardiac work, but the left ventricular contractility is preserved. In preeclamptic women, the peak mitral E wave velocity was greater in normotensive during the third trimester, which suggests a higher atrial pressure in the preeclamptic women. In our study, about 90% of the women had a normal ejection fraction, while only 6% had an ejection fraction of between 51 to 60%, and 2 women less than 40%. In the study done by Sajid, the mean ejection fraction of preeclamptic women was 67.5. Next. In our study, the patient with gestational hypertension, 18 women had diastolic dysfunction, among which 14% had grade 1 and 4 had grade 2. Whereas in preeclamptic group, total 37 women had diastolic dysfunction, of which 26 women had grade 1 and 11 had grade 2 diastolic dysfunction. Tanuja showed similar findings. In the birth weight, in our study, 55 women delivered low birth weight babies of less than 2.5. So coming on to the conclusion, preeclampsia is a latent disease of future cardiovascular disease. The possible mechanism of this relationship is that preeclampsia and cardiovascular diseases, they share common risk factors like obesity, diabetes, and renal disease. And alternatively, preeclampsia may induce long-term metabolic and vascular abnormalities. So our study shows that there is significant structural and functional changes in the cardiovascular dynamics in preeclamptic subjects, which is noticeable even in primigravida. So the maternal echocardiography could help to identify patients with acute heart failure and women who are at risk to develop cardiovascular complications later in life. Therefore, an echocardiographic assessment should be introduced into the routine management protocol of hypertensive disorder of pregnancy. Thank you.